Well, thank you, Vita. I appreciate the invitation and the interest of the society. I appreciate the audience's interest in this topic. So my first disclosure is I'm not a geneticist. Some of my best friends are geneticists, and certainly some of my best collaborators are geneticists. And I'm going to talk to you a bit about our genomic prescribing system. We have a pending patent application for that. We're certainly open to collaborations, and if there's any companies who would like to license our work, that would be great as well. And I received some modest royalties, a few $100s a year related to an old patent for UGT1A1 genotyping related to irinotecan. So this story goes back to 2006. Once upon a time, there was a young senator from Illinois, where I come from, named Barack Obama. And he had just been elected senator in 2004. And in 2006, he introduced this bill into the United States Senate, the Genomics and Personalized Medicine Act of 2006, to improve access to and appropriate utilization of valid, reliable, and accurate molecular genetic tests by all populations, thus helping to secure the promise of personalized medicine for all Americans. Now, Senator Obama was quite naive. He had no idea how to get legislation passed. He had no idea that he needed a co-sponsor from the Republican Party. And this bill got sent to the United States Senate Committee on Finance, where it was read twice, and then it died. But it was inspiring to see this. Some of my friends thought I wrote the bill. I had nothing to do with this bill, but was pleased to see it. And shortly after this bill, I was on my way to the first Cold Spring Harbor meeting on pharmacogenomics. If any of you have been to Cold Spring Harbor, it's a long way. And I flew into LaGuardia Airport in New York and had to first find my way to the hotel. And it was a long trip on a dark night, and it was in the rain. And I had no idea where I was going, not having spent much time in the New York area. And I got there, and then the next day was even worse, and I had Mary Relling in the car with me, and we were trying to find our way to Cold Spring Harbor. And again, we just kept getting lost. And by the time I got there, and here's Cold Spring Harbor, it's beautiful once you get there, I said, what we need is a GPS, okay? And a GPS, in this context, was a genomic prescribing system. And I said, that's what we need to build. We need to implement, in order to make pharmacogenomics happen, to really move discoveries into the clinic, we have to change the way we're using this information. And we need to stop talking about tests and think about prescribing systems. And for a prescriber, the information needs to be there when they prescribe. They don't want to order a test in order to order a drug. And so that was the concept. I published this paper in 2007 in Clinical Pharmacology and Therapeutics. It was just a short piece. And the view was that the world of pharmacogenomics would grow over time. This is a slide from 2011. I said, here are examples of useful tests on the left. I say useful. There were really just 3 that I was willing to say were definitively useful. A number of HLA haplotypes for hypersensitivity reactions. Hank Yan talked about the abacavir, also in Asian populations, carbamazepine and allopurinol. Hypersensitivity is predictable. Clopidogrel activation is through CYP2C19, which is polymorphic. And you heard about thiopurine methyltransferase. And then there was a group of tests I said are probably useful. We talked about the warfarin, that's still controversial, statins, thiopurine methyltransferase, when used to treat leukemias, the pediatric oncology community is less convinced. CYP2D6 for tamoxifen is still controversial today. And then things that are possibly useful, my own work on a UGT1A1 for irinotecan, we know how to reduce toxicity, but we don't know if that preserves efficacy. And CYP2D6 testing for codeine, sure, we can identify patients that cannot benefit from codeine because codeine requires activation by CYP2D6, but prescribers don't have to prescribe codeine when there are many other opioids, and so you don't need to do pharmacogenetic testing if you want to prescribe an opiate, only if you want to choose to prescribe codeine. So it was unclear as to the best way to make this all happen, but there's clearly useful information in pharmacogenomics, but being a physician myself, I knew it was not straightforward. So meanwhile, you heard about CPIC, the US parallel to what's going on in Europe, and this is led by Mary Relling. The CPIC philosophy was, if you had the genotype result, what should you do? CPIC has been funded by the US National Institute for General Medical Sciences as part of the PGRN. And CPIC has never chosen to weigh in on whether one should do genotyping, but it simply said, okay, let's assume you have genotyping information. What should you do? And CPIC, over the years, has developed 19 guidelines plus 8 updates. So the field has clearly grown over time, which was what we believed back in 2007 when we started talking about a GPS. Now, physicians, as I said, really don't like the whole concept of pharmacogenomics. Okay? While they acknowledge it's potentially useful, most physicians have no idea what to do with the information. Okay? Most physicians don't understand pharmacology. Most physicians don't understand genetics. So they're not going to understand pharmacogenetics. In addition, the availability of tests is quite limited. In the US, these tests are now being offered more broadly, but there's still very limited reimbursement if you actually follow the federal rules for reimbursement and tell the truth about the patient as to why you're ordering a test. So there are very few drugs for which you can justify to Medicare, our federal coverage system for the elderly, that a test is useful. And they're very specific tests that reimbursement is allowed. Physicians don't want to wait when they're prescribing a drug. They don't want to say, Mrs. Smith, I can't write you a prescription today. We have to order a test first, and then we have to wait maybe a week, maybe 2 weeks, maybe 3 weeks till we can get the result. And then we'll order the prescription. She goes, well, what am I supposed to do for my pain or my infection or whatever? And so it's just not practical. And then physicians are really concerned that if they order the test and they get the result, that they'll use the information inappropriately. So we said we can design a system to circumvent all of these barriers. And that was the GPS. And as I say, we don't do tests and we don't issue reports. This is a model for pharmacogenomic implementation. It's a system. We test all relevant pharmacogenomic variants, all variants for which one can provide any useful information to a clinician. We do it in a laboratory that is certified in the United States under the federal rules called CLIA, and we do it preemptively on a whole panel. By doing it in this way, preemptively and with a whole panel, it markedly reduces the cost because, as many of you know, one of the largest costs of pharmacogenomic testing is labor. Having to pay somebody to do the testing when the sample comes in, and by doing it in a preemptive, elective way, you can do these in batches and greatly reduce the costs. We address the lack of physician knowledge and physician concerns regarding interpretation and translation through a portal, which I'll show you, where hopefully the results that they're looking for are available before they even think they need them. And they were constantly updating the system, which is why we don't think issuing reports are appropriate, because the information is going to change over time. We coined the term the 1,200 Patients Project. When I first came up with this, I said, let's do 1,000 patients. And then a donor was said, why only 1,000? We'll give you money so you can do 1,200. So we did 1,200 and called it the 1,200 Patients Project. And this is not really my work. This work has been led by my colleague, Peter O'Donnell. The informatics piece of this has been built entirely by Keith Danahy, and all of the genotyping has been done by Jerry Yao. And so this is a large team effort, all at the University of Chicago. So for genotyping, we originally outsourced the genotyping to Chris Corliss at the University of Oregon. We started with Sequenom custom mass arrays, and then we decided that to bring it in-house and built a panel using Life Technologies custom open arrays. CYP2D6, as many of you know, is very complicated. We built our own CYP2D6 panel, a combination of hologic custom panel and TACMAN for copy number. And the assay that we use for CYP2D6 is published. If you're interested, you can find the paper. So this is an overview of the system, and it is intended to show that there's a lot of complexities. What we've really built is a software system. We've built a software system that takes information about the drugs that a patient is receiving or that a physician would like to prescribe and can make recommendations or provide what we call virtual consults written by physicians for physicians in the context of a patient's genotypes. And so this way, physicians do not actually need to know anything about genetics or anything about pharmacology. They just need to know when to ask a question and how to read the consult that comes back, which is written exactly like any consult that a physician would provide to another physician. And we built this to grow over time because the pharmacogenomic literature has grown over time. We found, looking backwards, and this is going back only to February 2012, there were 3,000 pharmacogenomic papers in PubMed at that time, and that's grown basically significantly. And so our view is that the field will continue to grow and that we need to be able to accommodate that through a system that does not provide static reports and can be cognizant of all developments in the field. The other problem that in this field was the whole issue of conflicting data, both false positive and false negative results in the pharmacogenomic literature, the difficulty by the average clinician in appreciating methodological flaws that explain discrepant results. So for many pharmacogenomic papers I see, this is my response. Why most published research findings are false. And if you haven't read this paper, you should, particularly if you're a trainee. And it's basically the typical candidate gene study where somebody makes a list of their favorite genes, their favorite genotypes, and then picks a few favorite phenotypes and cranks everything through a computer and sees how many p-values less than 0.05 they can find, and then publishes a paper. And of course, that's false discovery. And the pharmacogenomics field is plagued with this. And these papers are not being published in the genetic journals. Geneticists are no better. They're being published in the clinical journals, and they're reviewed by clinicians who have no idea about false discovery. And it is a plague on the entire field of pharmacogenomics. And then there's the whole problem of false negative and inability to understand and replicate. You've heard a little bit about tamoxifen and CYP2D6, and this story goes back to David Flockhart, who unfortunately died of a brain tumor a few years ago, who said tamoxifan's a prodrug. It's activated by CYP2D6. It's highly plausible that poor metabolizers of CYP2D6 will not benefit from tamoxifen or have less benefit from tamoxifen. And the original study, which was published in collaboration with the group in Stuttgart, clearly showed, and this was published in JAMA in 2009, clearly showed that women who received tamoxifen after their primary treatment for breast cancer, that were poor metabolizers had a greater and more rapid recurrence rate. So this was consistent with the pharmacology result. And then my oncology colleagues went about trying to replicate this study, and there were many negative replication results. Well, why did they fail to replicate? Well, oncologists have never really liked to collect blood for genetics, but they commonly collect tumors, okay? And so they said, all right, well, we've got these breast cancers in our tumor bank, so we'll just start testing them for CYP2D6. What's the problem? It's called LOH. And LOH is highly common in estrogen receptor positive breast cancer, the exact population that tamoxifen is indicated for. And in fact, we showed that in 41% of patients with estrogen receptor positive breast cancer, there was LOH at the CYP2D6 locus. So, and so it's not surprising that there was failure to replicate. There were studies published in high-impact journals with no report of Hardy-Weinberg, when in fact, when you actually tested the Hardy-Weinberg, it was less than 0 if that's actually possible. I'm joking. It was 10 to the minus 173 for the SNP of greatest importance. So, so that's a problem in the field as well. All right, so despite all that, we have built a system that has grown over time, and this is our shows for our GPS, how it's grown over time. We now have in the system over 40 drugs, and that's about twice as to where we started. The number of variants has grown over time. We're now testing over 100 variants, again, about a 2-fold increase over when we started. And we built a disease drug association tool. The details of this published in Clinical Pharmacology and Therapeutics. And 90% of the top 20 diseases could appropriately be treated with at least one medication with actionable pharmacogenomic information. And as I'll show you in a minute, that we basically, this allows physicians to, when they're looking at a drug, and they're to consider all drugs that are useful for a disease. So this is our current view of the system, and for a particular patient, the physician, when he or she logs into the system, sees a listing of drugs that the patient is on, and this particular patient is on 4 drugs: codeine, omeprazole, simvastatin, and clopidogrel. And this is hypothetical, and then gets a pharmacogenomic signal where red is bad, you know, there's something wrong here. Yellow is caution, there's something you should know here, and green is everything is fine. And then they're also told there are some pharmacogenomic alternatives that can be considered for some of these drugs. For codeine, the answer is none. For omeprazole, the prescriber is told there are some with green, some others with yellow. Simvastatin, the same. Clopidogrel, for which there's a green light, there would be no reason to switch. We also use levels of evidence where level 1 is the highest, and we go actually down to level 3 because we think that there's enough information out there that it may be worth even presenting level 3 information. So here's an example. So for simvastatin, and again, this hypothetical patient's at risk for statin myopathy, which is a fairly infrequent complication of statins, but some patients have a higher risk than others. And the physician is told, here are some alternatives if you want to decrease the risk: atorvastatin, for example, and then a couple of other non-statin agents that have been used to treat lipid disorders. So we give them information that allows them to come up with a different decision. The codeine example here, a physician can click through, and if they click through on the red signal, they get this consult. And this is what I mean by a virtual consult. So there's the box. This is like, you know, if all you want to know is, should you prescribe codeine at all, the answer is no. If you want to know more, which is why, your patient's genotype in CYP2D6 is strongly associated with an increased risk of toxicity, including CNS depression and potentially death. And this patient is an ultra-rapid metabolizer of CYP2D6 and converts excess amounts of CYP2D6 to the active metabolite. By the way, don't use tramadol either. And then we give them even more information about the pharmacology, and there are hyperlinks to the actual PubMed article. So it's scalable. It's a scalable virtual consult that is available to physicians anytime they want it. And all of our information is presented this way. There is no haplotype, there's no allele, there's none of the stuff that the average physician, without expertise in pharmacology, genomics, or pharmacogenomics, finds absolutely confusing about the field. So our study now has enrolled close to the 1,200 patients. We are continuing to enroll patients. And although I'm an oncologist, these are not oncology patients for the most part, and Dr. O'Donnell is also an oncologist. It's largely primary care and cardiology comprises almost half the population, and then a smattering of other disciplines. And Dr. O'Donnell is now getting ready to start a study in collaboration with our anesthesiologists for perioperative management and incorporating pharmacogenomics. And these are the top diseases in the enrolled patients: hypertension, hypercholesterolemia, I mean, things that are just seen in primary care, gastroesophageal reflux disease, obesity, arthritis, coronary disease, diabetes. So basically, really common diseases. These are not rare diseases. And these are the most frequently prescribed medications. And everything in brown, in other words, all but 3 drugs, there's some pharmacogenomic information in the system. So aspirin, atorvastatin, hydrochlorothiazide, pretty much all of the antihypertensives. There's some information, and this is potentially useful because there are many choices of antihypertensive therapy. So, how are we doing? So there have been over 3,500 clinic encounters where a patient who's enrolled in the study has come back to see their physician. And in 68% of them, the physician logs into the system. Okay, so that's step number 1. Okay, you can enroll the patient, you can do the genotyping. How do you get the prescriber to actually use the system? And so there's, do you incorporate this into the electronic medical record? That's not always straightforward because you have to deal with a whole different set of software people. And so we built a separate portal that physicians would have to log into, and 68% of the time they logged into it. At 89% of the visits, there was information available for at least one drug the patient was taking. I will add that to get into the study, you had to be on at least one regularly ordered regular prescription medication, and you couldn't be on more than 6. And the reason for that is once you get on too many drugs, the penetrance of the genomic information is modest compared to the drug-drug interactions. And so for 30% of the drugs in the system, there was information. For 70%, there was no information. And of the subset with information, 1.5% of the time there was a red signal, 37% of the time a yellow signal, and 61% of the time there was a green signal. So that's good. And what happened? Well, the system's working in the sense that the red signal encouraged the physician to figure out what's going on. So 100% of the time they said, okay, I need to know why. For yellow, 74% they checked, and for green, 42% of the time they checked. And physicians changed the drugs in response to the information. So for the red signal, 61% of the time they changed, not 100%, because it turns out that one of our red signals is that some of the proton pump inhibitors used to treat reflux disease won't work. In fact, many of these patients will resolve without treatment. And so the physician's attitude was, well, the patient's better, I'm not going to change anything. For yellow, 13% of the time, they made a change. For green, 9%, and when there was no information, 8%. So green is about the same as no information. Yellow is about 1.5 times higher. 56% of the time that we actually gave information, it influenced the decision to prescribe a drug, and 66% of the time when the information was delivered influenced medication discontinuation. So that's pretty good. So we analyzed the impact of this kind of information on medication change. And so this shows here a list of variables that we looked at and the odds ratio of medication change. So not surprisingly, the highest odds ratio for medication change was a red light signal, an odds ratio of 26, for a yellow signal, 2.4. And those were the only two variables that were statistically significant. And no pharmacogenomically high-risk medications were prescribed during the entire study when the physicians actually consulted the GPS system. And the providers acknowledged that their prescribing had changed. We asked before and afterwards, have pharmacogenomic results changed prescribing methods in the prior 6 months? And before, 67% said never, and after, 6% said never. And so, and as you see, when you lump sometimes, frequently, and almost, the majority of the time, majority of physicians said that pharmacogenomic results had sometimes changed prescribing by the time the study ended. And also, how informed do you feel about pharmacogenomics? Clearly, this is educational. So once a physician gets some experience with pharmacogenomics, they get educated about pharmacogenomics, which is not surprising. Here are some reasons provided for using the GPS to influence medication change. Primarily, it helped me make a more informed therapeutic decision, increased likelihood of favorable response, which was far more important than reduced likelihood of adverse reactions. And physicians are comfortable managing adverse reactions, particularly in the subspecialties, and are more concerned about in a scenario where the patient may not benefit. Help me select the dose, and 14%. Help me select the medication from multiple options. That's a very important concept for 49%. And confirmed a prescribing decision made before logging in, 26%. So a variety of reasons here. And the patients like this, which is really good. And we asked patients a whole bunch of questions, and basically the patients perceived that they were receiving personalized care in this context. And it was when the physician accessed the GPS, the patients had a 1.8-fold increase in perception of personalized care. And when prescriptions were actually changed based on the GPS, a 3-fold improvement in perception of personalized care. So this is good from a patient perspective. So we successfully implemented an individualized healthcare model, a preemptive pharmacogenomic testing, which we call a genomic prescribing system. Patient interest is robust. Physician adoption is high. These are not highly selective physicians. It's across the entire spectrum at the University of Chicago Medical Center. And the information improved prescribing in a pattern aimed at reducing patient risk. This is half full or half empty, depends how you look at it. Physicians log into the system on 68% of clinic visits, and patients are happier when their physician uses the GPS to prescribe. But they don't log in to the GPS on 32% of visits, and physicians only use the system for 16% of newly prescribed medications. So they could be, for any new medication, they could be looking at the system before they prescribe. So we're continuing to grow this project with a larger number of patients and physicians. We're now working with our hospitalists for inpatients. We're working with our anesthesiologists. As I mentioned, we want to do randomized trials where we can measure adverse events or non-response events. We really think it's important to engage the pharmacy community, both in academic centers as well as in the real world. And we're looking at the optimal way to integrate this fully with the EMR. So thank you for your attention, and I look forward to your questions.